Welcome back to Rebelcast. I'm your host, Salim Razai. This is episode 120. And oh my God, it's Etomidate versus Ketamine for rapid sequence intubation in the emergency department again. Now, a little bit of background for those of you who aren't privy to this ongoing debate, which we see all over social media. But I think most of us know rapid sequence intubation in the emergency department typically involves administration of some type of induction agent, followed by a neuroblocking agent in quick succession. And we also know that rapid sequence intubation carries with it just some inherent risks from the procedure itself, like post intubation hypotension and, in extreme cases, cardiac arrest. Now, is it possible that the induction agent that we use could maybe play an important role on some of these hemodynamic effects in critically ill adults? Well, that's why I brought the Swami back, because I think this is something that he and I are probably pretty close in our opinions on, but I think it's worth reviewing this paper because, Swami, I saw it making its rounds on social media and I felt like we should definitely weigh in on it.
Oh, yeah, for sure. I think this is a ripe one for us to take on. It is the effect of ketamine versus etomidate for rapid sequence intubation on maximum SOFA score, a randomized clinical trial in the Journal of Emergency Medicine. Lead author is Sarah Knack, but just to note, the other authors in this article include Jim Miner and Brian Driver, who we know as really some of the leading researchers in our field. Brian Driver is synonymous with airway research and airway analysis. And I think that kind of raises the stakes on a paper like this because we know these people, we trust the work that they do, we want to trust the work that they do. And I think it's important for us to get into this and really see what it means for all of us. Not necessarily the interpretations that we see on social media, but what it really means when we drill down into it. And I don't know, this happens, or this discussion happens all the time, Salim. I'm intubating somebody. Maybe they're a little tenuous on their hemodynamics. Maybe they're not. Should I reach for etomidate? Should I reach for ketamine? What's the best agent? Outside of shortages, ketamine is my go-to most of the time, but we both trained at the same time. Etomidate was not just like the go-to agent. It was pretty much the only agent for intubation for most of my residency.
Yeah, it was the same for me. And, the question these authors were trying to answer, which I think it's worth getting into like the details of this paper, was does a single dose of ketamine or etomidate used for rapid sequence intubation, or RSI for short, of critically ill adults in the emergency department impact the SOFA score within 3 days of hospitalization? So, Swami, what did they do? Let's just set the stage here.
Yeah, so a single center randomized parallel group trial comparing ketamine versus etomidate for RSI. They performed this study under the exception for informed consent, which is important only from a methodologic standpoint of how you get this through the IRB, et cetera. And the patients were randomized 1-to-1, either to get ketamine at 2 mg per kg or etomidate at 0.3 mg per kg.
Now, the primary outcome was, we've already stated it, was maximum SOFA score within 3 days of hospitalization. And some of the key secondary outcomes were post-intubation hypotension, 30-day mortality, and first attempt successful intubation. They included adults that were greater than or equal to 18 years of age undergoing RSI. We'll list all the exclusion criteria for you, but Swami, let's get into the results here a little bit.
Yeah, before we get to the results, I just want to mention one of the exclusions because they made some important caveats on it. Conditions in which elevated heart rate or blood pressure could be hazardous, those patients were excluded because of this myth around ketamine. But the authors are very explicit, saying that we do not believe that ketamine has any effects on heart rate or blood pressure. But this is just kind of how they had to put this study together in order to get it through the IRB. So I want to make that point only because I don't want people to look at this and be like, does Brian Driver and Jim Miner and Sarah Knack, do they think that ketamine's bad if you have something like a subarachnoid hemorrhage? And that's not what they're saying. They're saying, listen, we just had to do this. So I just want to make sure that that is clear to everybody. All right, let's get into those results. They included 143 patients in this trial. The most common indications for intubation were trauma, about 20%, and overdose, another 20%. The most common neuromuscular blocking agent was succinylcholine. The most common use of laryngoscope, and this is important because this is a particular area that this group researches on, was a Macintosh video laryngoscope that was used in 91%. So that's a standard geometry blade, but with a video on the end. 20% of these patients had a suspicion for sepsis. And that's also really important. We're going to get back to that in a moment. As far as did they receive the assigned induction agent, this was over 95% in both groups. So they really stuck to their protocols as closely as possible. Now, when we look at that maximum SOFA score, that primary outcome, they found that it was about 6.5 in the ketamine group, 7 in the Etomidate group. That was non-statistically clinically significant. And then when we look at those key secondary outcomes, there was no true difference in first pass success, so no statistically significant difference there, no statistically significant difference in post-intubation hypotension, and no statistically significant difference in 30-day mortality, although I will mention that while it wasn't statistically significant, the 30-day mortality was 21% in the Etomidate group and 11% in the ketamine group. That's a 10% difference. It just didn't reach statistical significance.
Yeah, I mean, that just shows you how small a paper it was and how well it would have to be, how much bigger it would have to be powered to even show that. Because I mean, that's a 10% difference, and it's still not statistically significant. So that
10% difference, number needed to treat of 10. I think that would matter to everybody if it was statistically significant.
So we'll leave the strengths and limitations of this paper basically in the show notes. But Swami, I want to get to the discussion of this paper because
Absolutely.
I mean, I think that's where this is where the weight of all this is. So the first thing I want to mention is that, for the first 103 patients, and you said they recruited 143, the primary outcome of the study was mortality at hospital discharge or at 30 days. But this got changed somewhere along the way to this confusing primary endpoint of maximum median SOFA score by 3 days after hospitalization. And they state that this was used as like kind of a surrogate of mortality. Now, whether that's actually true or not, that's a whole nother discussion, but it did get changed. The primary outcome did get changed somewhere along the way after they had recruited about 2/3 of their patients.
And it's really unfortunate because, a SOFA score really is a non-patient centered outcome. I mean, I understand it's patient adjacent, but when you compare that to mortality, there's really no real comparison there. We want that mortality. That's the thing that we want to see. In general, I would look at this and be like, is one medication given once going to impact mortality? Usually I would say no. But again, in that secondary outcome, we did see a 10% difference. So it would be great if we had that larger study where we could see, was that 10% real? Even if it was a 5% difference, so even if it was a 2 or 3% difference, I think it would matter to us. So I'm a little bit concerned and upset that they changed the primary outcome because I would have much rather have seen mortality as that hard endpoint patient center that we're looking at.
I wish they could have stuck with it. Now, Swami, you had mentioned something at the very beginning of this podcast that I think is worth commending these authors for. And that's basically just the lengths they went through to get this study approved to be a randomized clinical trial.
Yeah, absolutely. I mean, there is clinical equipoise at this point. I think if you asked most physicians that are doing intubation in the emergency department, they would say, I don't know that Etomidate is better than ketamine or ketamine is better than Etomidate in terms of this kind of an outcome. And so that leaves us with that clinical equipoise, which means we can do a randomized control trial, but getting consent is impossible in this circumstance. Most of these patients are going to be altered. They're not going to be able to give consent. And so you have to set up this way of doing consent, basically where the patients don't have to give consent. It's a assumed consent, and that's kind of the way that it has to be done. And so again, this group does really good work with figuring out how do we do this the most ethical way? How do we do this that it protects patients? And how do we put a study together that's acceptable? And they actually go to their community and they say, hey, this is something we want to do. We want to figure out what the right answer is. They get community input and then they write their IRB proposal, and patients can elect out. They can actually get these bracelets that they wear and say, I don't want to be in these studies. So patients always have the ability to exclude themselves prior to them needing the procedure. But once they need the procedure, they don't have to get emergency consent. They don't have to find a surrogate. They can include them because of this exemption from consent.
And I think this is the way we should go from now on with RCTs where there's clinical equipoise in these emergent patients, because it's near impossible to get that consent from them. So you go to the FDA, you kind of show them the evidence for equipoise, you go to your community, make sure this is okay with them, and then you kind of write that protocol and you go forward. And I think this is going to get us a lot more answers instead of like having to use like other outcomes or not being able to do it as a randomized clinical trial. So I think they should be really commended because this wasn't like one or two check boxes they filled out. They went to like a lot of effort to make sure that this could get done as an RCT and something that we don't really have a good answer for.
Absolutely. Now, Salim, when we were talking about this paper before we started recording, you said these results don't surprise me at all. I don't think that that's what everyone thought going into this paper or thought when they read those conclusions. I think there was a lot of surprise, but why doesn't this surprise you?
Yeah, so there was a few things. So first of all, over half the patients that got included in this trial, they got intubated for airway protection, not because they were hemodynamically or physiologically in a tenuous position. There was just no derangements. And let me give you some hard numbers. So the median systolic blood pressure prior to intubation in this trial was 140 millimeters of mercury. I wish every patient I was ready to intubate had a systolic blood pressure of 140 millimeters of mercury.
Oh, yeah.
Only 10% of the patients were anticipated to have any type of clinical deterioration. And we even said that only 10% were projected to be septic. And so, how sick from a hemodynamic standpoint was this patient population? The second thing I would say is that let's look at the median oxygen saturation at induction. It was 100% in both groups. 100%. I wish all the patients I was intubating had an oxygen saturation of 100% prior to pushing RSI meds. Only 7% got intubated for hypoxemia. Only 22% of patients were intubated for respiratory failure. And then the final thing I'm going to say here, Swami, is that a SOFA score, which we don't typically calculate in the ED, but it is something that's used up in the ICU. It ranges from 0 to 24. And the higher the score, the higher the mortality. A score of 0 to 6 is associated with a less than 10% mortality. A score of 7 to 9 is associated with a 15 to 20% mortality. The maximum SOFA score in this trial was 6.5 in the ketamine group, and it was 7 in the Etomidate group. And essentially, what I'm getting at here, Swami, is that one, this was not a sick patient population. They weren't clearly hemodynamically unstable for the most part. They weren't in respiratory distress for the most part. And from a mortality prediction standpoint, they just weren't that sick. And so, as you stated, would you really be surprised to find a difference in a not sick population that's just getting intubated for airway protection, whether a single agent or another is really going to have that type of impact at 3 days?
Yeah, it's weird to say that it's a group that I'm intubating, but they're not that sick. But it's true. It's true because of the indications to intubate here and why we really bandy about which agent to use for intubation that's going to protect the hemodynamic state of the patient the most. And I think we do care about that, obviously, but we want to really look at a higher risk group overall. So a patient group that maybe had a positive shock index or their systolic was under 100, or by the clinician's estimate, they were hypoperfused. That would be kind of the more relevant population to look at. One of the things that we also always talk about in critical care and resuscitation and in intubation is the fact that the agent is likely less important than the dose that we're using. Now, when it comes to etomidate and ketamine, this is a thing that we have been looking at more recently. Does it really matter with etomidate and ketamine what the dose is? Because those agents don't really have intrinsic hemodynamic properties. So I don't know that it really makes a difference if I use 0.3 per kilo of etomidate or 0.1 per kilo of etomidate for the hemodynamics of the patient. But I do know that if the patient themselves is hemodynamically stable, it is less likely that any agent I use and any dose I use is really going to have any kind of an impact. If you're using propofol for intubation, then I do think that the dose that you use is very important. If you're using midazolam, stop using midazolam. That is a terrible agent for induction. But those are agents where they do have intrinsic hemodynamic properties that would lower based on the dose and where the dose would make a difference. Etomidate and ketamine probably doesn't make as much of a difference, but the reason why these may be linked to worse outcomes later on, especially etomidate, is because of etomidate's ability to suppress adrenal function, which we've looked at in the past and said it doesn't look like it impacts mortality. Although now with accumulating data, we're saying, well, maybe there's more of a signal here than we thought there was. And so these are not surprising data because of the group that we were intubating. And I guess when we look at a trial like this, Salim, what we want is to have better direction on what we do in the patient that we care about asking this question. And I don't know that this data moves us forward in that regard.
Yeah, unfortunately it doesn't. And I think you hit the nail on the head here. It's the days of rapid sequence intubation in the critically ill need to go away. And what we really need to be focusing on is resuscitation sequence intubation, optimizing their pre-oxygenation, optimizing their hemodynamics, whether that be with fluids or vasopressors or inotropic agents. And then, some would even argue that we need to start thinking more about a delayed sequence intubation where we kind of like use this time period instead of just rapidly pushing meds to kind of optimize these patients. And I think that's where our focus needs to be in these critically ill patients. But unfortunately, this was not a trial of critically ill patients. And then the final thing I'm going to say, Swami, is that I do think the authors overstep here a little bit because they come out and say in their conclusion that, um, ketamine or etomidate don't affect the incidence of post intubation hypotension. But this was a secondary outcome of which we just talked about how the study's not big enough or powered well enough to really give us any definitive answers. I mean, a 10% difference in mortality, and it's still not statistically significant, just tells you how much bigger this trial would need to be. And so I think that was a bit of an overstep. It's not a knock on the authors. I just think that that's a hypothesis generating secondary outcome based on the type of trial we're reviewing here.
I agree. And let's put out their conclusion because I think that helps to make this a little bit clearer. They state there was no significant differences in maximum SOFA score or post-intubation hypotension between critically ill adults receiving ketamine versus etomidate for RSI. And again, the problem there is, yes, in this data set, they did not find a difference in the SOFA score. That is true. That should be in their conclusion. But the post-intubation hypotension piece, like you said, is a secondary outcome, doesn't really give you that information. It's really an association here only, and we would need a future study really looking at that as a primary outcome. But again, I think when we get into the clinical take home, people are going to kind of see what we think about this, that it didn't really affect post-intubation hypotension in a group that you didn't think was going to have any issues with hemodynamics.
And that brings us to our clinical take home point, which is when the majority of your intubations are done on a group of patients for airway protection, i.e., a low GCS, who really don't have any physiologic or hemodynamic derangements prior to intubation, it probably doesn't matter which agent, ketamine or etomidate, you use for intubation as a one-time dose, because you wouldn't expect that to have any effect on mortality, or in this case, what they used as a surrogate, 3-day maximum SOFA score. Well, there you have it, Rebel EM listeners. Please leave us your thoughts, comments, and questions. Thanks for tuning in, and until next time.